So you're running out of closet space. The good news? You don't need to stop shopping. You just need to start selling with The RealReal. The RealReal is the world's largest and most trusted resource for authenticated luxury resale. Whether it's that mini bag that can't even fit your phone, or those boots you never fully broke in, The RealReal handles everything from photography and copywriting to shipping and pricing. So you can just sit back, get paid, and make room for things that actually feel like you. And with 10,000 plus new arrivals every single day from top designers like Prada, Celine, Louis Vuitton, and Loewe, all for up to 90% off retail, you're bound to find something perfectly on brand to fill that extra closet space with. Plus, right now, you can get an extra $100 to shop when you sell for the first time. Make room for what feels like you. Go to therealreal.com to start selling and get your extra $100 to keep shopping at therealreal.com. That's therealreal.com. Terms apply.
This podcast is sponsored by Talkspace.
Last year, I went through many different life changes. I needed to take a pause and examine how I was feeling in the inside to better show up for the ones who need me to be my best version of myself.
When you're navigating life's changes, Talkspace can help. Talkspace is the #1 rated online therapy, bringing you professional support from licensed therapists and psychiatry providers that you can access anytime, anywhere.
Living a busy life, navigating a long-distance relationship, becoming a first-step father, Talkspace made all of those journeys possible. I could speak with my therapist in the office. I could speak with my therapist in the comfort of my home. I was never alone.
Talkspace works with most major insurers, and most insured members have a $0 copay. No insurance, no problem. Now get $80 off your first month with promo code SPACE80 when you go to Talkspace.com. Match with a licensed therapist today at Talkspace.com. Save $80 with code SPACE80 at Talkspace.com.
If you're a podcast host, listen up, this one's for you. My name is Allie Jackson. I'm the host of Finding Mr. Height, a dating and relationship podcast that I've been doing for 4 years now, sharing my positive and practical approach to dating that's built on my own life experience. And I wanted to share another experience that I've had, my secret behind monetizing my show. It's called Red Circle, and I was just telling my colleague about how much I love their platform. With Red Circle, not only am I getting a seamless hosting experience, but I also love the support I receive in ad sales. It's not just typical ad sales either. It's targeted opportunities based on my show and my life. And the platform is super simple. You just set your preferences and Red Circle matches you with sponsors that align with your show. You can vet every opportunity and their platform gives you great analytics. More recently too, my Red Circle team has brought me opportunities outside of my podcast on social media to really augment the podcast partnerships, bring them full circle. I just can't recommend them enough. If you want to give it a try, go to redcircle.com to get your free trial. That's redcircle.com for a free trial.
There's a finding in the exercise science literature that I think changes how most people should think about fat loss. In studies where subjects did aerobic exercise for months and didn't lose a single pound, the scale didn't move start to finish. Visceral fat still dropped by about 6%. The diet-only group, the same body weight, no weight loss, they showed about 1%. The same scale number, but roughly 6 times the effect on the fat that most directly predicts metabolic disease. But the scale didn't register any of it. That gap between what the scale reports and what's actually happening inside your body is what this episode is all about. We're going to cover the biology of fat distribution, why some fat is categorically more dangerous than other fat, how to actually measure the right things, and what the evidence says about the best ways to change them. Some of what we cover is going to push back on things that you've probably heard. I'm Dr. Jordan Feigenbaum. This is the Barbell Medicine Podcast. The scale is measuring the wrong thing, but not because it's inaccurate. A good scale is very accurate. The problem is what it's measuring. Scale weight combines every tissue compartment in your body into one single number. That's skeletal muscle, bone, organs, blood volume, the glycogen stored in your liver and muscle, whatever's in your GI tract right now, and several liters of water distributed across every cell in your body. Now, none of those compartments are static, and all of them vary independently of fat tissue, and some of them vary considerably. Take glycogen storage. It alone varies by 300 to 500 grams based on what you've eaten in the past 48 hours. And each gram of glycogen holds roughly 3 to 4 grams of water alongside it in the cell. So that means that a carb-heavy weekend, dinner out, a few drinks, birthday cake, they can all add 2 to 4 pounds to your scale reading, and that has nothing to do with fat tissue. Even after a hard training session, the inflammatory response in stressed muscle draws in additional fluid. You can wake up a pound or 2 heavier after a workout you'd otherwise be proud of. 2 to 4 pounds is the typical scale swing from a single carb-heavy weekend through glycogen and water retention alone. but that's zero change in fat tissue. And that's the floor of the noise that you're working with. There's a density issue too. Skeletal muscle has a density of about 1.06 grams per milliliter. Fat tissue sits at 0.9. And that means that a pound of fat occupies roughly 15 to 20% more physical space in your body than a pound of muscle. Yeah, 1 pound of fat is the same as 1 pound of muscle on a scale. Fat just takes up more room. Now, if you've been training and replacing lower density fat with higher density muscle, your body is getting physically smaller while the scale stays flat or drifts only modestly. Clothes fit differently, your waist is getting smaller, the scale is unimpressed because mass is mass regardless of what it's made out of. This, though, is body recomposition, losing fat while preserving or gaining lean tissue simultaneously. And it produces some of the best health outcomes available, but the scale is completely blind to it. If the scale hasn't moved but your waist has, something is clearly working. The tape measure is just picking up something that the scale can't. Scale weight combines everything into one number, which makes it nearly useless for tracking fat specifically. What we actually want to track is where the fat is, and that requires a different tool and a short detour into some biology that may change how you think about your midsection. Not all fat is the same, and the type that lives inside your abdomen is operating on a completely different set of biological rules. You can have a completely normal BMI and be carrying dangerous amounts of the most metabolically disruptive fat in your body. Doctors sometimes call this normal weight obesity. That's when the person looks relatively lean, their height to weight ratio is normal, but internally they're carrying significant visceral fat that standard health screenings usually don't catch. That's because these screenings typically just use BMI and people often skip the waist circumference. I had a consultation with a gentleman not too long ago about weight management. He had a normal BMI and on paper he looked relatively healthy until I had to measure his waist and it was at 40 inches. He also sent me his labs and they told a different story too. He had impaired fasting glucose, his triglycerides were elevated, and he had low HDL. Every metabolic marker was pointing in the same direction, and this has probably been building for years, while everyone around him, including himself, was reassured by a normal BMI. Nobody had measured his waist. That scenario is more common than you think, and it's the reason why fat distribution matters more than fat amount in some cases. And when we say fat, subcutaneous fat is what most people think about. It sits between the skin and the muscle. You can grab it. You can find it on your hips, thighs, arms, and on top of your abdomen. Abdominal subcutaneous fat is relatively quiet, metabolically speaking. It produces fewer inflammatory signals per unit mass than visceral fat, and it doesn't drain directly into the liver. Peripheral subcutaneous fat at the hips and thighs appears to be actively protective in some respects. It efficiently traps circulating free fatty acids, and it produces hormones like Adiponectin that seem to support metabolic health. Women store proportionally more fat here than men, which is part of why premenopausal women have a substantially lower cardiovascular risk profile than age-matched men at a similar BMI. Now, visceral fat is anatomically different. It sits inside the abdominal cavity, packed around the intestines, the liver, and the pancreas. You can't see it or feel it from the outside. Someone can look lean standing in front of you and be carrying substantial visceral fat internally. So what is visceral fat actually doing? The honest answer is that the scientific literature has 3 competing theories, and they're not equally supported by the evidence. Now, the first and most well-supported framework is what's called the overspill and ectopic fat hypothesis. The idea here is that visceral fat isn't necessarily a primary independent cause of metabolic disease. It's more accurately a marker that the body's safe subcutaneous storage capacity has been exceeded. Now, every person has what some researchers call a critical fat storage threshold. When subcutaneous capacity is saturated, fat overflows into the visceral compartment and, more importantly, into ectopic storage sites, primarily the liver. It's this ectopic fat accumulation, particularly liver fat or hepatic fat, that does the most direct metabolic damage. The data supporting this interpretation is pretty compelling. When researchers put visceral fat and fatty liver into the same statistical model and ask which one predicts metabolic syndrome independently, fatty liver wins decisively. In one analysis with an odds ratio exceeding 70, while visceral fat lost its independent significance entirely. When surgeons have selectively removed large amounts of visceral fat during bariatric procedures and compared outcomes to weight loss alone, there's no consistent additional metabolic benefit beyond what the weight loss itself produces. If visceral fat were an independent primary driver of disease, removing it surgically should provide a clear benefit above weight loss alone. The evidence, though, hasn't reliably shown that. The visceral depot appears to be a highly visible signal of a broader systemic problem rather than the main culprit itself. So that's the first theory. The second theory is the portal theory, and it's the one you hear most often. The fat depots inside the abdominal cavity drain through the portal vein, that goes to the liver, and every free fatty acid and inflammatory molecule released by the visceral fat goes straight into the liver circulation at concentrations the rest of the body never sees. The liver responds by producing more glucose, developing insulin resistance, and subsequently accumulating fat. And this cascade eventually is what produces metabolic syndrome. Portal vein concentrations of interleukin-6 are measurably higher, roughly 50%, when compared to systemic levels, which confirms that visceral fat is doing something that the portal theory predicts. But the theory's primacy is challenged by those same omentectomy trials. If the portal drainage route were the primary mechanism, severing it surgically should rapidly improve hepatic metabolism above and beyond what weight loss alone produces. Consistently, it hasn't. So the portal mechanism is real and contributing, but it's probably not the, quote, root cause. The third theory is hormonal, and it operates through a feed-forward loop that's worth understanding in some detail. Visceral fat overexpresses an enzyme called aromatase, which converts testosterone into estrogen. In men, elevated estrogen signals the brain to reduce testosterone production. The brain is more sensitive to estrogen than testosterone in this regard. Now, lower testosterone levels then make visceral fat cells more efficient at accumulating or sequestering incoming fat from the bloodstream, which drives more aromatase activity, which drives testosterone lower. The loop runs in both directions and doesn't stop on its own. Now, this mechanism is well validated, but it's better understood as a secondary loop that accelerates fat accumulation and complicates fat loss rather than the foundational driver of cardiovascular or metabolic disease. We'll come back to it in detail later because the clinical implications, particularly for men, are significant and usually under-discussed. On top of these three mechanisms, visceral fat also releases proteins called adipokines that function as hormones. For example, visceral fat increases the secretion of PAI-1, plasminogen activator inhibitor 1, which impairs the body's ability to break down blood clots and creates a state of elevated clotting risk. It also increases Angiotensinogen, which feeds directly into the renin-angiotensin-aldosterone system and contributes to hypertension, also known as high blood pressure. It also paradoxically underproduces Adiponectin, the adipokine that normally increases insulin sensitivity, reduces hepatic glucose output, and protects blood vessels from plaque formation. More visceral fat means less adiponectin, which means less of the signal that protects you from the consequences of carrying visceral fat. That's a meaningful effect. I think that cardiorespiratory fitness is a confounder that's worth mentioning here because large prospective cohort data consistently shows that people with high fitness and high body fat have substantially lower cardiovascular mortality than people who are lean and unfit. Fitness partially decouples adiposity from mortality risk. This doesn't mean that visceral fat isn't a useful target. It clearly is. But the relationship between fat and health outcomes is not as clean as a simple linear story. Now, let's talk about how to actually measure visceral fat, because this is where a lot of the nuance lives and where most health communication falls short. MRI and CT are the gold standards for directly quantifying visceral fat volume. In clinical practice and for tracking at home, we use waist circumference as a proxy, and it's a reasonably good one. Imaging studies show that waist circumference correlates with total abdominal fat above 0.8 in most data, and with visceral fat specifically around 0.7. Those correlations are good enough for tracking change over time, which is what we actually care about. But here's where it gets more complicated than most people realize. There are 3 different standard measurement sites for waist circumference, and they don't give you the same number. First up is NHANES. This is the large U.S. population surveillance study that provides many of the reference ranges used in American medicine. It measures at the iliac crest, the top of the hip bone. This is typically the lowest point of the trunk. The WHO standard measures at the midpoint between the bottom of the lowest rib and the top of the hip bone. The WHO standard measures at the midpoint between the bottom of the lowest rib and the top of the hip bone. And this is what was used to validate the widely cited clinical thresholds for waist circumference, 94 centimeters for men and 80 centimeters for women. Then there's the umbilicus, your belly button. It's the most practical site for self-tracking. One, it's the easiest landmark to hit consistently on your own. You can see it and feel it. And it shows the highest sensitivity to visceral fat changes over time when it comes to manually measuring your waist. It does typically read a few centimeters higher than the WHO midpoint site in people carrying central fat. Now here's the practical implication. If you're measuring at the belly button and comparing it to the 94 and 80 centimeter clinical cutoffs for waist circumference, those are the ones that were validated at the WHO midpoint site, those thresholds are approximate guideposts for you, not necessarily hard lines. The trend matters more than where you land on any single reference anyway, so pick one site, measure it the same way every time, and track the direction. We recommend the belly button because it's just easier to locate. As far as how to measure, it should be first thing in the morning, after you go to the bathroom, but before you eat anything. You should be standing up straight and relaxed. Exhale gently and measure without bracing your trunk. Take 3 measurements and average them out. For the waist to height ratio, you can divide your waist circumference by your height as long as you're using the same units. A ratio below 0.5, so your waist is less than half of your height, is associated with substantially lower cardiovascular and all-cause mortality across virtually every population studied. Now, the main thing here is you want to be below 0.5, but above 0.4, because that indicates that somebody might be carrying insufficient amounts of body fat. Still, waist to height ratio seems to outperform BMI as a single number predictor because it captures centrally located fat rather than just total mass. This is one of the reasons why we put it in the Barbell Medicine Vital 5. Now, there are ethnic-specific thresholds for waist circumference, and the biology behind why they exist matter more than what they're usually given credit for. For people of Asian descent, the clinical thresholds are lower, roughly 85 to 90 centimeters for men, 75 to 80 for women. For many South Asian populations, even tighter cutoffs have been proposed. And for individuals of West African descent, the standard thresholds may actually overestimate metabolic risk at a given waist measurement. Now, these aren't necessarily arbitrary adjustments because they do reflect genuine differences in body composition and fat distribution that have specific biological origins. For any given BMI, individuals of South Asian descent carry higher mean body fat than people of European descent, with a greater proportion stored viscerally or in the abdomen. Individuals of West African descent tend to carry greater lean mass and lower total body fat at the same BMI. The relationship between an anthropometric measurement like BMI or waist circumference and actual internal fat distribution varies meaningfully by ancestry. The tool is reading something real, but what it's reading does vary by population. The evolutionary biology behind this is genuinely interesting, though I want to be clear up front that what follows is kind of a hypothesis, not necessarily settled science. One framework, called the variable disease selection hypothesis, proposes that these differences in fat distribution reflect long-term genetic adaptations to the specific infectious disease pressures these different populations faced over thousands of generations. It's an interesting argument, but the research is still developing and we should interpret it accordingly. But the argument goes something like this. Immune responses are metabolically expensive. Different pathogens impose different metabolic demands. Populations that are faced with intense pressure from specific types of infections may have evolved fat storage patterns that were optimized for fueling the immune responses those pathogens required. South Asian populations historically faced severe gastrointestinal infections, which monsoon conditions made endemic. The hypothesis is that visceral fat, positioned directly around the organs involved, draining to the liver, and capable of releasing energy and inflammatory signals into that local circulation, they may have been selectively favored as a fuel depot for mounting rapid, local immune responses against gut-borne pathogens. The architecture that makes visceral fat metabolically problematic in a modern environment of calorie surplus may have been adaptive in an environment where gut infections were a leading cause of death. For populations with intensive historical exposure to malaria, a different pattern may have been favored. Malaria treatment requires sustained, metabolically expensive fevers. Intramuscular adipose tissue, so that's fat stored directly within the muscle tissue, provides a local, immediately accessible fuel source for the high metabolic demand of a fever. The hypothesis here is that populations facing heavy malarial burden may have evolved towards higher intramuscular fat storage for exactly that reason. Now again, these are hypotheses, not proven mechanisms, but they provide a biologically grounded framework for why identical waist measurements carry different metabolic implications across ancestries, one that goes deeper than an arbitrary clinical adjustment. The populations are genuinely different in ways that likely have deep historical roots. Okay, now let's talk about what the relationship between waist change and waist circumference change can actually tell you about the quality of the weight that you're losing. If you lost 10 pounds over the last 2 months, how much would your waist have changed? Most people couldn't answer that, and neither could their doctors. But that ratio is one of the most useful monitoring tools available, and it tells you something specific when it's off. Across studies tracking weight loss, the commonly cited figure is approximately 0.7 kilograms of weight loss per 1 centimeter of waist reduction, about 1.6 pounds per centimeter. Worth noting, the primary data behind this number comes from studies conducted in men. That matters for interpretation, and we'll come back to the sex differences shortly. For now, though, treat it as a rough orientation rather than a universal benchmark. In high-quality, structured weight loss programs where the people are doing progressive resistance training, they're taking in adequate protein, and they're doing their conditioning, the ratio improves. 6-month intensive interventions have shown waist reductions of 10 to 14 centimeters alongside roughly 6 kilograms of weight loss. putting the ratio in the 0.4 to 0.6 kilograms per centimeter waist circumference reduction range. Less weight loss per centimeter of waist reduction because more of what's coming off is fat. At the other end, rapid weight loss without resistance training often pushes the ratio above 1 kilograms per centimeter waist circumference loss. That's the signal that lean tissue is being lost alongside fat, and lean tissue loss barely moves the tape measure. The scale cooperates, but the waistline doesn't. So the reference figure is roughly 0.7 kilograms per centimeter. Call it about 3/4 of a kilogram per centimeter, and remember this comes mainly from male study populations. Well-designed programs can get that ratio down towards 0.4 to 0.6, but if you're above 1.0 over 8 to 12 weeks, lean mass loss is likely playing a significant role. Again, these are population averages, and individual variation is wide, driven by sex, baseline fat distribution, age, and the specifics of the weight loss program. Again, we can use them as calibration benchmarks, not as precise predictions. Back to the sex thing, women tend to show a less favorable ratio than men, particularly in the early phases of weight loss. 3 kilograms of weight loss corresponds to about 3.5 centimeters of waist reduction in men versus about 2.8 centimeters in women on average. The explanation here is fat distribution. Women store proportionally more fat in peripheral subcutaneous depots, the hips, the thighs, the gluteal region, and those depots tend to be mobilized before the abdominal depot responds significantly. The waist catches up, but typically later on in the weight loss journey. So what does this practically mean? We can track the weight and waist circumference under consistent conditions. First thing in the morning, after you go to the bathroom, but before you eat. Daily weights averaged into a trend line are generally more informative than a single weekly number. The day-to-day swings from glycogen and fluid are noise, and the moving average filters them out. For waist circumference, weekly measurements at the same site are sufficient. You don't need to do it more than once a week. But over 8 to 12 weeks, if the weight is dropping but the waist isn't moving proportionally, particularly if the ratio is running above 1 kilo per centimeter of waist circumference reduction. If the waist is shrinking and the scale is flat, that's body recomposition, and you should enjoy it while it lasts. Ultimately, the scale tells you how much mass you've lost. The ratio tells you what that mass is made out of. And one of the less intuitive findings in the literature is that exercise doesn't just change the ratio by preserving lean mass, it targets visceral fat through a completely different biological mechanism that operates even when the scale doesn't move at all. But before we get into any interventions, there are 2 underappreciated factors that actively work against this whole program, and they don't get positioned that way often enough. The first is sleep. Sleep deprivation dysregulates 2 appetite-related hormones, leptin, which signals satiety, and ghrelin, which drives hunger. When you're constantly undersleeping, your hunger signals are elevated and your fullness signals are blunted, independent of anything else in your program. 7 to 9 hours of reasonably high-quality sleep is where the metabolic data lands. This isn't necessarily just a lifestyle recommendation, it's to help your physiology here, specifically around hunger and satiety. If you're chronically undersleeping, you're working against your own hormonal environment, regardless of how well the rest of the program is designed. I wonder if that's what influencers mean when they say you have to balance your hormones. Speaking of hormones, the second thing here is cortisol, and I want to be specific here because the cortisol belly narrative has been both overstated and underdiscussed at the same time. The mechanisms are real. Visceral fat carries a higher density of glucocorticoid receptors than subcutaneous fat. Those are receptors for cortisol. Adipose tissue also contains an enzyme that locally regenerates active cortisol from its inactive form, which means that the visceral fat storage site is experiencing elevated cortisol activity even when a blood cortisol level looks normal. This is pretty well established. Now, the population level effect is much smaller than the wellness industry is telling you. A meta-analysis of 14 prospective cohorts, over 23,000 subjects, found essentially no meaningful relationship between psychosocial stress and subsequent weight gain. About 69% of the included studies found no significant relationship. The main driver of stress-related body composition changes is behavioral: eating more, moving less, sleeping less, and not a direct hormonal rerouting of the fat into the visceral storage site, at least not by cortisol anyway. Addressing the behavior matters, and you should save your money on cortisol-blocking supplements because they're not really doing anything. Sleep and cortisol don't get the last word in the story, but they have earned a place early in the conversation about what's working against you. If you've seen my Instagram lately, you know that my new house is currently a construction zone and my schedule is a bit crazy. Between everything that's going on, the last thing I want to do at 8 p.m. is chop vegetables and then deal with the cast iron skillet for 20 minutes. Factor has been my lifeline here. They are fully prepped meals designed by dietitians and chefs that actually taste like real food. I've been leaning hard into the Muscle Pro collection because the macros are pretty spot on for my training, But they also have over 100 rotating options, including the Mediterranean diet, a higher protein option, even something for those that are on GLP-1s. Now, the quality is actually there. We're talking about lean proteins, colorful vegetables, and healthy fats with no added sugars or anything that you don't want. It's always fresh, never frozen, and they're ready in about 2 minutes. I use this myself almost daily because it's the only way that I'm hitting my targets right now without living in the kitchen. Head over to factormeals.com/BBM50off and use code BBM50off to get 50% off and free breakfast for a year. Eat like a pro this month with Factor. New subscribers only, varies with plan, one free breakfast item per box for 1 year while the subscription is active. That's factormeals.com/BBM50off. This podcast is sponsored by Quince. Now, we talk a lot about high yield strategies in the gym, and I think that logic should apply to your closet so you can look your best when you're not in athleisure wear. Personally, I've been focused on efficiency, finding pieces that look good, mix well, and actually hold up over time. And that's where Quince shines. They offer everyday essentials like short sleeve cashmere polos and Pima cotton tees that stay soft and do not pill. They also have European jersey linen that is breathable and lightweight for when the weather starts to shift. Now, the reason that the price is so much lower than what you see at high-end malls is that Quince works directly with top factories and cuts out the middlemen. You're essentially getting luxury materials without the brand markup. These pieces are rated between 4.5 and 5 stars by thousands of people, and they only partner with factories that meet rigorous standards for craftsmanship and ethical production. I've been wearing a few of their overshirts and their Pima t-shirts lately. They look great and feel expensive, but they definitely didn't cost a fortune. No need to overcomplicate your wardrobe. You just need a few pieces that actually work. Right now, go to quince.com/BBM for free shipping and 365 days of returns. That's a full year to build your wardrobe and love it. And you will. Now available in Canada too. Don't keep settling for clothes that don't last. Head to quince.com/BBM for free shipping and 365 days of returns. That's quince.com/BBM.
Hey, Sal.
Hank, what's going on? We haven't worked a case in years.
I just bought my car at Carvana, and it was so easy. Too easy.
Think something's up?
You tell me. They got thousands of options. Found a great car at a great price. And it got delivered the next day.
It sounds like Carvana just makes it easy to buy your car, Hank.
Yeah, you're right. Case closed.
Buy your car today on Carvana. Delivery fees may apply.
If you're a podcast host, listen up, this one's for you. My name is Allie Jackson. I'm the host of Finding Mr. Height, a dating and relationship podcast that I've been doing for 4 years now, sharing my positive and practical approach to dating that's built on my own life experience. And I wanted to share another experience that I've had, my secret behind monetizing my show. It's called Red Circle, and I was just telling my colleague about how much I love their platform. With Red Circle, not only am I getting a seamless hosting experience, but I also love the support I receive in ad sales. It's not just typical ad sales either. It's targeted opportunities based on my show and my life. And the platform is super simple. You just set your preferences and Red Circle matches you with sponsors that align with your show. You can vet every opportunity and their platform gives you great analytics. More recently too, my Red Circle team has brought me opportunities outside of my podcast on social media to really augment the podcast partnerships, bring them full circle. I just can't recommend them enough. If you want to give it a try, go to redcircle.com to get your free trial. That's redcircle.com for a free trial.
Now let's talk about the finding I opened the episode with, this time with the mechanism behind it. In studies where aerobic exercise produces no meaningful weight loss, they have the same body weight start to finish, visceral fat still drops by about 6%. Dietary restriction alone, without exercise and without weight loss, it's only about 1%. It's the same scale number, but roughly 6 times the visceral fat effect through a completely different pathway. This comparison is directional, not a controlled head-to-head analysis. The exercise and diet-only groups in that analysis aren't perfectly matched, but the finding is consistent across the literature, and the mechanism explains why it has to be there. Visceral fat cells have some unique receptors that other cells don't. They carry a higher density of beta-3 adrenergic receptors, the receptors that respond to adrenaline and related catecholamines by activating fat release. They also carry a lower density of alpha-2 receptors, which normally serve as a brake on fat mobilization. The net effect? Visceral fat responds far more readily to the catecholamine surge from vigorous exercise, especially aerobic exercise, when compared to subcutaneous fat. These receptor differences may have an evolutionary origin. Visceral fat appears to be built to function as a rapid-release fuel reserve, one that drains directly to the liver through the portal vein during periods of intense physical demand or stress. The architecture that makes it metabolically problematic in a sedentary, calorie-surplus environment is the same architecture that makes it preferentially responsive to vigorous exercise. During a hard workout, especially if it's conditioning, the sympathetic nervous system produces a catecholamine spike. That's noradrenaline and adrenaline, and these hit the visceral fat preferentially. This is one reason people who exercise consistently tend to carry lower visceral fat at the same body weight compared to people who don't work out, even when total calorie intake is similar. Repeated adrenergic activation from exercise is specifically mobilizing that internal fat storage site. The second mechanism is where things get really interesting, because this is all about myokines. These are proteins secreted by contracting skeletal muscle that act as hormonal signals to other tissues. During vigorous exercise, working muscle releases interleukin-6 at levels 5 to 30 times above resting levels. This exercise-derived interleukin-6, or IL-6, enters the systemic circulation and acts on fat tissue to stimulate fat mobilization. The combination of visceral fat's receptor architecture and the circulating IL-6 signal means that visceral fat is being targeted through two independent pathways simultaneously during every hard training session. Your skeletal muscle, the tissue that is moving your body, is releasing a signaling molecule that tells fat cells to release stored energy. That's happening independently of the calorie deficit. Let's take a second with that. Your skeletal muscle, the tissue that moves your body, is releasing a hormone that tells fat cells to release stored energy. That's happening independently of what's going on with calories in and calories out. It's just a different biological pathway, and it's one that pure dietary restriction doesn't activate. Now, when it comes to exercise, aerobic training and HIIT, high-intensity interval training, generally outperform resistance training for acute visceral fat reduction. The catecholamine response and the calorie expenditure per unit of time from cardiovascular work are the primary drivers here. And meta-analysis found that exercise alone produces about 6% visceral fat reduction versus 1% from diet alone. That's the adrenergic and myokine mechanisms at work. Resistance training's contribution to visceral fat operates on a longer timeline. Lean tissue built or preserved through lifting weights protects resting metabolic rate, and prospective data consistently shows that lifting weights is more protective against age-related waist circumference gain over years than equivalent conditioning volume. The mechanism is metabolic, preserving the tissue that keeps your baseline energy expenditure elevated. Now, when diet and exercise are combined, the waistline effect is larger than either produces alone. Head-to-head trials show diet alone produces waist reductions around 2.2 centimeters over a typical intervention period, 8 to 12 weeks. Now, when we combine diet and exercise, then we see about a 5.7 centimeter reduction in waist circumference over the same time frame. Adding exercise also cuts lean mass loss roughly in half, from about 20 to 30% of weight lost as lean tissue on diet alone, down to approximately 10 to 15% when exercise is included. As far as how much exercise is needed, the aerobic dose where visceral fat reduction reliably shows up in the data is around 150 minutes of moderate intensity work per week. There's still more to be had above that as more volume drives more effect because there's a dose-response relationship here. Now, those mechanisms operate through the adrenergic and myokine pathways. They require physical contraction. You've got to exercise. This brings up a clinically important question about GLP-1s, which are the most effective weight loss pharmacology that we've ever seen. These drugs, semaglutide, tirzepatide, and the emerging triple agonist retatrutide, they produce weight loss through appetite suppression and delayed gastric emptying mostly. They create a calorie deficit primarily by reducing hunger, but they don't activate the adrenergic pathway. Also don't produce the myokine signal, and the body's response to a sustained calorie deficit, regardless of how that deficit is created, is to draw on both fat and lean mass. This is exactly where the weight-to-waist ratio becomes clinically useful for people using these drugs. If the deficit is being created pharmacologically without exercise pathways being activated, the ratio tends to suffer. More lean mass in the mix, less waste per kilogram lost. This isn't a reason not to use these drugs necessarily, especially when they're clinically appropriate. It's a reason to understand what needs to be added to get the most out of them. Consider this. Semaglutide at full dose produces an average of about 15% of initial body weight loss. Tirzepatide, a dual GLP-1 and GIP agonist, reaches about 20%. Both show real reductions in visceral fat and liver fat that translate to improvements in metabolic syndrome. The direction is clearly right. But the body composition data is more complicated. DEXA substudies from the STEP 1 trial. This is X-ray technology that looks at body composition and bone mineral density, and the STEP 1 trial is what looked at semaglutide over 68 weeks. Well, approximately 39% of the total weight loss was lean mass as measured by DEXA. Tirzepatide does a little bit better. The SURMOUNT-1 trial showed that lean mass losses were about 24%. Retatrutide, again, that's that triple agonist targeting GLP-1s, GIP, and now glucagon receptors, shows around 33% lean mass in a recent study published in Lancet Diabetes and Endocrinology. But before drawing conclusions from those numbers, we need to go through some context. DEXA measures lean mass as everything that isn't fat or bone, including actual skeletal muscle, but also water, glycogen, organ tissue, and intramuscular fat. That's important. Fluid and glycogen shifts during rapid weight loss gets recorded as lean mass loss, as does intramuscular fat loss, which is a favorable adaptation. DEXA records them as lean mass loss too. These percentages from these studies likely overstate the actual skeletal muscle loss. We have some evidence to show that that's likely true. The SURPASS-3 MRI substudy tested this directly. It looked at fatty infiltration within the muscle, something we call myosteatosis, when people were using tirzepatide. The drug significantly reduced intramuscular fat compared to placebo, and that's a favorable adaptation, and it's exactly the kind of change DEXA would misattribute to lean mass loss. Functional data also points in the same direction. In the SEMALEAN study, patients on semaglutide showed a 4.5 kilo improvement in hand grip strength at 12 months, without exercise, mind you. And the prevalence of sarcopenic obesity dropped from 49 to 33%. A recent review concluded that skeletal muscle changes with GLP-1 treatments appear adaptive rather than pathological. That said, a 24 to 39% lean mass loss on DEXA is comparable to what diet-only interventions produce without resistance training, which isn't really a high bar to clear. But what would happen if these drugs were combined with something that actually preserved muscle mass? And that's what the BELIEVE trial demonstrated directly. Bimagrumab, a myostatin pathway blocker, combined with semaglutide, produced 22% total weight loss, with 93% of it coming from fat mass, versus 72% coming from fat mass with semaglutide alone. The direction the field is moving is towards protecting lean mass while producing fat loss, and the pharmacology to do that is beginning to exist. For people on GLP-1 agonists, adequate protein, which is around 1.6 grams of protein per kilogram body weight per day, and resistance training that is progressively loaded make a meaningful difference to what's being lost and what's being preserved. The drug handles the deficit. What you do alongside of it shapes the composition of the outcome. Before we move on, I want to address something directly, because the public conversation around GLP-1 agonists and muscle loss has a framing problem that I think is doing real harm to real patients. Now, the argument you'll hear from a lot of popular health media goes something like this. GLP-1 agonists cause lean mass loss, therefore they're dangerous. Therefore, people should be cautious about using them and otherwise skeptical. That argument treats the risks of the medication as if they exist in a vacuum, as if the alternative to taking the drug is something other than continuing to carry the weight. But here's what the lifestyle intervention data actually shows for people with obesity. Across intensive lifestyle programs, the best ones with dietitians, behavioral support, structured exercise, consistent follow-up, roughly 1 in 10 people achieve and maintain clinically significant weight loss at 5 years. That's a success rate for people who engage with these programs. The other 9 are not dropping out or failing to try hard enough. It's just that the biology of weight regulation is genuinely difficult to override through effort alone, and suggesting otherwise is moralizing weight loss. These anti-obesity medications produce clinically significant weight loss in a substantially higher proportion of patients. Semaglutide at full dose averages around 15% of starting body weight. Tirzepatide does even better, closer to 20%. Again, these are average outcomes, not the best case scenarios. And when it comes to the muscle loss question, we just covered what the trial data actually shows. DEXA percentages that likely overstate real skeletal muscle loss because of fluid, glycogen, and intramuscular fat changes. Meaningful reductions in myosteatosis on tirzepatide, hand grip strength improving on semaglutide, sarcopenic obesity prevalence dropping substantially in the SEMALEAN data. The concern is real, but the framing, that these drugs are consuming your muscle, it just doesn't hold up against the evidence when you look at it carefully. And there's also an intellectual consistency issue worth naming. The same people raising the loudest concerns about lean mass on GLP-1 agonists are largely not applying that same scrutiny to unregulated peptides, to aggressive calorie restriction without clinical supervision, or to vitamin D maxing, which is a documented cause of hypercalcemia and kidney damage when people take it in the quantities that some corners of the internet recommend. The selective application of alarm, specifically targeted at a drug class that is effective for obesity, is worth noticing. Untreated obesity at the clinical level carries a substantially elevated risk of cardiovascular disease, type 2 diabetes, sleep apnea, several types of cancer, osteoarthritis, fatty liver disease, and all-cause mortality, to name a few. The conversation about whether a patient might lose some lean mass that is substantially preserved with adequate protein intake and lifting weights, has to happen alongside the conversation about what happens to that patient if they don't lose the weight. Now, none of this means that GLP-1 agonists are appropriate for everyone, or that we should put them in the water, or that the muscle loss data doesn't deserve attention in clinical practice. It certainly does, and we've walked through how to account for it. It means that the risk-benefit analysis has to include both sides of the coin. Appropriate use in the right patients with the right support isn't a controversial position. It's just medicine, and there are no gold stars for going throughout life without needing medicine. Now let's come back to the aromatase loop that I introduced earlier, because the clinical picture here is worth going through carefully. Visceral fat overexpresses aromatase, which converts testosterone to estradiol, a type of estrogen. In men, elevated estradiol feeds back to the hypothalamic pituitary gonadal axis, which is the brain to testes pathway for testosterone production. The hypothalamus reduces GHRH output, the pituitary follows with less luteinizing hormone, that's LH. With less LH reaching the testes, they produce less testosterone. Visceral fat is directly suppressing testosterone through this pathway. Testosterone deficiency then worsens the situation in a specific way. You see, testosterone normally inhibits the enzyme responsible for pulling triglycerides out of circulation and into the fat cell. When testosterone falls, that inhibition is lost. That means the visceral fat becomes more efficient at accumulating fat, which drives more aromatase activity, which suppresses testosterone further. The loop runs in both directions and it compounds over time. Now, to be clear, aromatase is one of several ways that visceral fat reduces testosterone levels. Insulin resistance, which visceral fat promotes through the portal mechanism, directly impairs testosterone synthesis at the level of the testes. Elevated inflammatory cytokines from the adipose tissue, those are the Adipokines, suppress the hypothalamic pituitary gonadal axis independently. And then there's detail from more recent research that often gets overlooked. When estradiol conversion was pharmacologically blocked in men with adequate testosterone levels, they gained body fat regardless of their testosterone dose. Estrogen, when it's produced naturally with testosterone present, appears to be critical for the body's ability to regulate fat accumulation. The clinical tendency to suppress estrogen in men on TRT, especially by TRT clinics, well, that can undermine exactly what you're trying to accomplish metabolically. See this pattern all the time. Gradual central weight gain over the years, declining energy, and decreased libido. The interpretation is usually testosterone deficiency, which may be true, but the cause is most commonly visceral fat accumulation driving the hormonal changes, not a primary testosterone deficiency that's driving the fat gain. Treating the testosterone without addressing the visceral fat leaves the underlying loop running. Testosterone's effect on body composition operates differently across 3 ranges, and which range you're in determines what's actually happening and what intervention makes sense. In testosterone deficient men, those with confirmed low testosterone on laboratory analysis, and they have symptoms, testosterone, or specifically the lack thereof, is genuinely limiting to body composition. Restoring it to normal physiological levels produces real changes. Lean mass begins increasing within the first month. 1 to 3 kilos over the next 6 months is representative in the literature. Visceral fat reduces over the same time frame as insulin sensitivity improves and the inhibitory effect on fat accumulation is restored. Now, within the normal physiological range, or Eugonadal range, this is roughly 300 to 1,000 nanograms per deciliter, depending on the lab. Testosterone is no longer the rate-limiting factor for muscle gain. The training stimulus is. This is why men at the lower end of normal and men at the upper end of normal gain similar amounts of lean mass in response to the same resistance training program. The signal to the androgen receptors is sufficient across that range. What determines how much muscle mass is gained is the training load, not where the testosterone level sits. Now, above the normal physiological level, this relationship changes. High doses of testosterone produce androgen concentrations well beyond what the body could ever generate on its own. At these levels, a clear dose-dependent relationship between testosterone exposure and lean mass emerges that simply isn't present within the normal range. The most well-described mechanism for rapid muscle growth and strength increases is forced cellular remodeling of muscle tissue. Supraphysiological testosterone levels stimulate aggressive myonuclear addition from the satellite cell pool. These are basically stem cells for the muscles that can be called into action to help a muscle grow. To simplify, the more myonuclei someone has in their muscles, the more muscle protein can be produced, which means more potential muscle size. This overcomes the intrinsic biological constraint of the myonuclear domain, allowing muscle fibers to grow to sizes unattainable in the eugonadal state. This is also the structural basis for the 2 to 3-fold greater absolute gains in fat-free mass and strength observed when supraphysiological testosterone is combined with exercise. High doses likely augment the non-hypertrophy-related strength gains, i.e. improved motor unit recruitment and contractility via non-genomic pathways, and significantly enhance recovery by reducing muscle protein breakdown. The most direct evidence for this is a controlled study that randomized men to 4 different groups for 10 weeks. Placebo with no exercise, placebo with resistance training, supraphysiological testosterone levels with no exercise, and supraphysiological testosterone with resistance training. The no exercise testosterone group gained more lean mass than the exercise only group. Testosterone plus exercise produced the most muscle gain. The anabolic signal at supraphysiological concentrations is strong enough to drive muscle protein synthesis without a training stimulus. Exercise amplifies it substantially, but is no longer a requirement to produce the effect. Fat mass also decreases at these concentrations directly through androgen receptor-mediated inhibition of fat uptake by the cells, and indirectly through the increased lean tissue raising resting metabolic rate. The cost side is also dose-dependent and worth being clear about. Regardless of whether someone is on replacement doses, that's testosterone replacement therapy or TRT, or if they're on supraphysiological doses of testosterone, endogenous production of testosterone shuts down. That's what your body normally makes on its own. The hypothalamic pituitary gonadal axis, or HPG axis, detects exogenous androgens from outside the body and stops generating it on its own. Recovery after stopping depends on the dose, the duration, and the specific compounds used, and can be prolonged in some individuals. Based on the most recent evidence, TRT level doses tend to produce neutral to beneficial changes in blood lipid levels and do not increase heart disease risk. At supraphysiological doses, however, the lipid picture worsens, as does the risk of heart disease and a number of other conditions. How someone weighs the risks and benefits is a personal decision, but the takeaway is that the effect of testosterone on body composition varies wildly from testosterone deficient to normal to supraphysiological levels. There's one more pharmacological tool worth knowing about, mostly for what it reveals mechanistically. Tesamorelin is a synthetic growth hormone releasing hormone. That means it bumps up growth hormone, and it stimulates pulsatile physiological levels of growth hormone release from the pituitary. Now, this was used for HIV-associated lipodystrophy, mostly due to the medications that were being used to treat HIV at the time. And lipodystrophy just means, hey, people got storage of fat in weird areas. In this case, the visceral adipose tissue site, which was harmful. So in this population, it produced roughly a 15 to 20% reduction in the visceral fat area with essentially no change in subcutaneous fat. Now, to be clear, tesamorelin is FDA approved only for HIV-associated lipodystrophy. The evidence in general obesity populations is limited, and its absolute effect on visceral fat is pretty small when you compare it to GLP-1s. It's really not competitive as a clinical tool for most patients in its current form. Its value instead is more like a proof of concept. The growth hormone axis can be selectively targeted to preferentially mobilize visceral fat without disturbing subcutaneous fat. And in fact, this is another one of the reasons why exercise works. When you exercise, growth hormone levels go up, and that growth hormone binds to the growth hormone receptors in the visceral fat, and that can reduce visceral fat storage. Now, whether that mechanism at some point becomes clinically useful in the future, well, that is an open question. Here's where everything we've covered comes together in a practical framework. The primary measurement is waist circumference. Pick a site, the belly button being the most practical for self-monitoring, and measure it consistently. First thing in the morning, after you go to the bathroom, but before you eat, standing up straight, being relaxed. Exhale gently, don't brace or tense your midsection, and take 3 measurements. Average them together. You can do it once a week. That's totally sufficient. The 2 reference numbers to keep in mind are 94 centimeters for men, which is about 37 inches, and 80 centimeters for women. That's about 31.5 inches. These are the WHO midpoint thresholds, so if you're measuring at the belly button, treat them as approximate. For people of South Asian descent, the thresholds are lower, and for individuals of West African descent, they may actually overestimate at a given measurement. For those people, we can use a waist-to-height ratio, and below 0.5 is a good predictor of lower cardiovascular and all-cause mortality, again, provided it's above 0.4. It generally outperforms BMI across ethnicities because it captures central fat rather than just total mass. Again, that's why we made it a part of the Barbell Medicine Vital 5. For tracking the quality of the weight lost, the reference figure in general programs, again, derived primarily from studies in men, is about 0.7 kilograms of weight loss per centimeter of waist reduction. Well-structured weight loss programs are lower, 0.4 to 0.6. But if the ratio runs above 1 over 8 to 12 weeks, lean tissue loss is likely a significant contributor. The levers here are protein intake. Make sure that's at least 1.6 grams of protein per kilogram body weight per day, and make sure you're lifting weights in a progressively loaded fashion. As far as exercise goes for visceral fat reduction, aerobic work is the primary driver through adrenergic and myokine pathways, targeting visceral fat through mechanisms that calorie restriction doesn't touch. Around 150 minutes of moderate intensity work per week is where the visceral fat reduction signal reliably appears in the data, but there's a dose-response relationship above that. Lifting weights doesn't produce the same short-term visceral fat loss, but it does protect lean mass loss during any calorie deficit. It also helps preserve resting metabolic rate long-term and appears to be more protective against age-related waist circumference gain than equivalent amounts of conditioning over the years. Both modalities have a role and they're both doing different jobs. We should do both. Getting a sufficient amount of high-quality sleep is important to make sure that the hormonal environment around you supports what you're doing. Pharmacological options like GLP-1 agonists and TRT in appropriately diagnosed testosterone deficient men, well, they work best when lifestyle inputs are in place, and they produce better compositional outcomes when people are eating enough protein and they're lifting weights. TRT in genuinely testosterone deficient men addresses the aromatase loop from both directions simultaneously, and seems to have a net beneficial effect when it comes to lipids. GLP-1 agonists are clinically powerful tools whose body composition outcomes are substantially better when there's an exercise foundation in place. For most people, exercise and diet are the foundation. Getting enough sleep makes everything work better. And if these lifestyle interventions plateau, or if the clinical situation indicates we should move faster, pharmacological support can be useful, especially with GLP-1s. If we go back to the person from the introduction of this podcast, they did months of exercise, but the scale was flat the entire time. They still lost 6% of their visceral fat. Nobody told them this was happening. The scale certainly didn't. But the tail of the tape measure and the ratio are the instruments that track what actually matters here. And it's worth knowing how to use them. And now you do. I'm Dr. Jordan Feigenbaum. Thanks for listening to the Barbell Medicine Podcast. Catch you next week and every week right here on the Barbell Medicine Podcast.
If you're a podcast host, listen up, this one's for you. My name is Allie Jackson. I'm the host of Finding Mr. Height, a dating and relationship podcast that I've been doing for 4 years now, sharing my positive and practical approach to dating that's built on my own life experience. And I wanted to share another experience that I've had, my secret behind monetizing my show. It's called Red Circle, and I was just telling my colleague about how much I love their platform. With Red Circle, not only am I getting a seamless hosting experience, but I also love the support I receive in ad sales. It's not just typical ad sales either. It's targeted opportunities based on my show and my life. And the platform is super simple. You just set your preferences and Red Circle matches you with sponsors that align with your show. You can vet every opportunity and their platform gives you great analytics. More recently too, my Red Circle team has brought me opportunities outside of my podcast on social media to really augment the podcast partnerships, bring them full circle. I just can't recommend them enough. If you want to give it a try, go to redcircle.com to get your free trial. That's redcircle.com for a free trial.